If you guys would take care of the person, we wouldn't have any problems.
That's history.
Okay, so it started like an hour ago. Levi!
What were you doing when the paint started?
I was just kind of watching TV, but I had just come back from my time at the racquetball court. I've been back for about an hour. Yes?
Are you sure, Brett?
A little bit, yeah.
All right, 40.
Or bypass.
Sick or not sick?
Sick.
How sick?
Really
Very
Am I gonna die?
Yes.
Really? Based on like 3 questions and this information, which not a whole lot has changed from our.
You're sick.
I'm sick, but am I gonna die?
Who knows? We may save you, we may not.
True. Based on the
You may cash out
Justin.
from the way.
Generally an active person?
Yes. Am I generally an active
Is
person?
that like the stint or whatever?
Yes.
Bypass guy.
Other options.
Yeah, I took some
besides
Tylenol. Yes.
Is AMI active? MI?
Acute
Acute
myocardial infarction with a
Coronary artery bypass graft.
Mons is so smart.
Acute myocardial infarction or ischemia? Infarction?
infarction. I had a heart attack and had to have a cabbage. It was actually red cabbage, which I really enjoyed.
I like
It had nothing to do with the coronary artery bypass graft. Once again, Mons ruins the whole scenario. Now we go down the rabbit hole.
There you go, Mons. Way to go.
Okay,
This
so
will just make it more interesting.
I have a history. I have a history of heart problems. Yes, everybody
Yes.
agree?
Yes.
Yes. Pinnacle diaphragtic. Agree?
Yes.
Can I
Yes.
die?
Yes.
Maybe.
I would say I could possibly die. Just with the history of what I know so far and what I'm
And
looking
chest
at.
pain.
Is anything else jumping out at you?
Heart rate of 40.
Heart rate 40.
Heart rate of 40.
We're
is
gonna
that
give this
normal?
guy
Oh,
atropine.
Medications is he on?
Not with
We
the.
talked about this.
We did just talk about this. I'm on no medications except they
it.
put me on an aspirin a day. Keeps the doctor away.
So that means you're decompensating even more if your blood pressure's low and your heart rate's low.
Give him atropine.
Decompensated.
You want to give me atropine?
Actually, no. I'm sorry. I don't want to do that.
Dude, no, not yet,
Sorry,
man.
he's unstable. I want to.
No.
Atropine is unstable.
Focus. Let's bring it on back. Okay. All right. So, no one wanted to give atropine. All in favor of giving atropine, just raise your hand.
I would like to see a rhythm.
I mean, like.
Well, I mean,
We haven't seen
I'd like a little more history, but
Rhythm.
I wouldn't give atropine unless I saw a rhythm.
You want to see a rhythm?
Yes,
I'll
I
give you
want
a
to see a
rhythm.
rhythm.
I'll give you a rhythm, all right.
With all of our whiteboard, that we have nothing left.
No,
Use it all up.
I mean, if you don't.
You can erase that.
Erase the drugs.
Uh-oh. Uh-oh.
At a rate of 40.
You can erase the algorithm.
So this is what you're talking about where you might not want to.
Am I taking any drugs? Aspirin.
No,
ED drugs. Am I taking any ED drugs? I don't know what ED drugs are.
erectile dysfunction.
That's a good sign, isn't it?
Sexual enhancement drugs.
Nope, I'm good.
I'm good there.
Okay. Amanda. What's that? Clear equal bilateral.
Okay, no,
lung sounds are equal, so
lung sounds good.
fluids. Lung sounds are
I
good.
take that back. So maybe a little bit of noises. It's kind of hard to see. Yeah, lower. Both bilateral lower. You know what kind of?
Yeah.
Yes.
Yeah.
And maybe a little bit of rouse, maybe.
Do you have a history of
Maybe a little bit of
respiratory
crackles.
illness?
Crackles.
Maybe.
Do you have a history?
We can't.
Chad. Yes.
What was that, JVD?
Yeah.
Yes. JVD.
Is there a tracheal?
Pericarditis.
Huh?
There's no tracheal deviation, I'm assuming.
No, everything feels good.
Okay.
There is
There's
JVD?
JVD.
Or
There's
there's,
JVD, yes.
okay.
Can we get
No
a 12
tracheal
lead?
deviation.
12 lead. Shows that right there. Sinus 380
What, what,
at 40
Heart
with ST
sounds.
elevation.
what limb?
Chandler.
Playing racquetball, did you have a meniscus impact? Did the heart mode ball impact?
No.
Where on your 12 lead was that showing?
Everywhere.
Everywhere.
When you were
Chad.
pain subsiding with breath?
No. Just keeps getting worse. I'll give you a hint. This is 9 out of 10 crushing chest pain. Non-radiating, nothing changes, nothing provokes it. Quality, I already got that. Onset of less than an hour while at rest.
You don't wanna make it
Secondary
worse.
to post
You don't wanna
racquetball.
speed up
So you guys get past medical history, agree?
Yes.
Am I sick?
Yes.
No, you gotta listen to the heart.
How are you gonna fix this?
Fluids and transport.
Mona.
Mona, will we get Mona?
Yeah. Oh, no fluids, no fluids.
Wait, we-
The lungs.
We got the lungs.
You're gonna wanna get on CPAP.
How do you monitor it?
It's not wet though.
It is. He's got wet lung sounds. Because he said it was clear, and then he said it
Very
wasn't.
slight, very slight. Hold on, hold on,
Mr.
hold on. Let me
Box.
clarify some stuff so you guys can think clearly. Very slight crackles, very slight respiratory distress. The only thing that's really bothering me is this substernal crushing chest pain.
Would you?
And you have JVD?
What are heart sound, how do heart sounds sound like?
They sound like a heart going boom.
Are they like hard to hear at all, or
I don't know. I don't know.
They're not muffled?
are they muffled?
I don't know. Do you know what a muffled heart sounds like?
I would.
Okay, then no.
Is the, kind of aside, but is the lung sounds because, so you have JVD because it's getting backed up, so it's getting backed up into the lungs too? Is that the reason why?
I don't know why. I'm just.
Well, it's getting backed up in the lungs.
Right.
Are you
Kind
asking
of
me?
aside.
Are you asking me as an
Aside.
instructor or as
Yeah.
the patient?
Instructor.
Okay, because I was like, as a patient, I was like, I don't even know what you're talking about right now, like this whole backing up thing. Okay, so why, so I gave you just slight, I'm not overflowing,
Yeah.
there's not a lot of fluid in there, but I'm telling you, there's a little bit of fluid in there, okay? So if you're backing up there, and you have the potential for backing up for your JVD as well, so if you have the potential for backing up both sides, so basically everything's backing up.
Full backup.
Full backup, okay?
You have pedal edema too?
Slight.
Just like-
Have you been sick?
No. No, I do not have a fever. Sick or not sick?
Sick.
Am I gonna die?
Yeah.
Yes.
No, unless
How are you
we
gonna fix this?
No, because we're awesome medics.
You guys are awesome medics, which I agree completely.
We're gonna get them to the hospital
Most days.
so fast, and they're gonna
Oxygen.
do a.
No, we're not doing diesel therapy, okay? I
So,
wanna know how you guys are gonna fix this.
Aspirin.
Brooke, how you gonna fix this?
so are you thinking pericarditis, or are you thinking?
We already said it.
I think it's kind of like left side.
I'm refusing to go until you give me a good
Oh,
reason
but I
why I
guess
need
that's
to
true.
go.
But the left-sided failure, would that be backing up in the JVD as well?
I think it was a full backup, so it's backing up into the lungs, which is then backing up into the right side, which is like backing up and causing G. But it has to be left-sided in origin, otherwise there won't be lung sounds.
Okay,
Because if it's just right-sided, you'd have
okay,
lung sounds.
very close. You guys all catch
Right.
that?
No.
Oh, is that because you guys are busy with all your own stuff going on?
Yes.
No,
No, it wasn't.
You're not paying attention, I see, you guys, okay, so 1, 2, 3, 4, 5, okay, 7 more timeouts. Josh, you wanna add them to your rubric here? Okay, so, Brooke says that, everything's backed up, the heart's sick, heart's not working, and, needs to make it to the cath lab. You guys all agree?
Yep.
I agree 100%. Is this person in shock?
Yes.
Yeah.
Is this hypovolemic shock?
No.
Cardiogenic.
The pump.
So remember, we're going back to our issues, right? So if it's not a rate problem, well, we potentially got a rate problem, right?
Yeah.
So would we fix this rate?
No,
Why not?
because you don't want to make this heart worse.
Because it's trying to not work very hard, so it preserves itself.
So the heart in this phase right now is it is attempting to recover itself, right? Like it is trying to shunt itself from having to do extra work. So it is slowing down because it is realizing stuff's going on in here, right? So it's going to self-assess and determine, I'm gonna slow down so I don't have to pump anything faster. So we do not want to give this patient atropine. Everybody agree?
Yeah.
Everybody agree, Noah?
Yeah.
Is that because of the JVD?
Nope, it is because we have an
The
acute
STO.
MI happening. We have
Because the STL.
It's gonna make it
ST
worse.
elevation
the rate
happening.
goes
It will make
faster.
it worse. If you increase the work of the heart, so now it has to pump more to increase that pressure. So it's
For more
working
cardiac
harder.
output?
More cardiac output,
It's not in
puts
our-
more demand on the heart, increases oxygen demand. It's not getting it. It's gonna make the ischemia worse.
Isn't that
Okay.
protocol?
So we're not gonna give this patient atropine, What about Harmona? We talked about.
Nitro would make
We
it worse.
can't because
Titrate oxygen to 92%. Don't give nitro. Give
Why not?
aspirin
I want to give nitro.
because their blood pressure's below 90.
It decreases the preload, which means the heart doesn't fill up with blood, and then you go to pump it, and it has not as much blood to pump around the body. Makes sense.
If you dump their blood pressure more, they're
So
not
if
going to perfuse.
You dilate the
anything.
blood vessels
Then
going into the heart, less
we're not
blood
gonna
could get
bump up
into the
with
right
fluid because they got
ventricle,
fluid build
meaning
up,
less
right?
blood could get
Yeah.
pumped out of the right ventricle,
So, like, we just wanna
decreasing
keep them-
the work of the heart.
Do we have blood in there already? Is
Yes.
there blood? Is there enough blood in there to?
Yeah, we're
So
perfusing.
if you,
Too much.
yeah. Yeah.
So what's not working correctly here?
The pump.
The left side of the pump.
So nitro is only going to make things worse, right? Because it's going to affect our container portion of it,
Right.
right? It's going to mess with our container. So the heart is doing basically everything that it can. So what works the opposite of nitro?
Dopamine.
Dopamine, right? So dopamine is your constrictor, your vessel constriction. So we do not want to dilate and make our container bigger, right? Because then our heart's having to pump a whole bunch more. Do we want to give this person fluid?
No,
No.
Why not?
because the lung sounds are bad.
Right. So we know we're good on fluid then, right?
So does this come into our box?
Yeah, it'd be
Uh,
bad
This is
lungs,
like a
bad,
pressure one.
bad
This is
lung.
our
Bad and
BP
bad.
good, lungs good. We can do.
No,
full
lungs
on.
were bad.
BP good, lungs bad,
I don't know.
nitro
We're
bad,
bad.
BP bad, lungs good, fluid, and BP bad, lungs bad.
That's where we're
Pressure.
Yes. It falls right into your box then.
Yes,
First time I've seen that box. That's kind of
it
cool.
was
box.
a Tom thing. Tom Cruise.
Yeah. So lungs, we got fluid in them already, right? So we don't want to overflow that. Okay. So we already know we're having pump issues, we're having circulation issues. So we're not going to overflow that. So we're not going to increase. Should we pace this person to increase the rate?
no.
Because it's not. I mean, it's taking the work of the heart, right?
No.
As what?
Yeah, the heart's
Compensating.
compensating. We don't, just like we don't want to slow the ventilations of our DKA patient because they're compensating.
Right, so we don't want to pace this person because it's going to do the same thing that the atropine's going to do, just using electricity versus chemicals, right? The heart is still going to beat faster, which then increases the oxygen demand. So, boom, out goes the pacing. So, hey, we're flying through this bradycardia protocol, right? That's kind of where we're at, because we have a rate problem, but yet the rate is actually helping us right now. Funny thing is we had this call last shift. So, what did the crew do?
Pace. Wanted to.
No, because they're my crew. So what did my crew do?
You gave them O2.
Gave
and
dopamine.
aspirin.
Okay, they called the doctor, and the doctor says,
Two-
hey, give dopamine. They're like,
2 to 20
That's the
mics
conversation.
per kilogram per
well,
minute.
it's funny because like it's very rare. You never get the order because it's MD order. You never get the order for dopamine, right? Because it's a sick person. But we just had the conversation like 3 shifts before. Hey, you got somebody with a major MI, bradycardia. What's the thought? And then we walk through with the new guy, and we're like, hey, yeah, you gotta go with dopamine because you don't want to increase, and you don't want to. Is the exact conversation we're having right now. So, dopamine, right? So dopamine has multiple different levels of dosing. You go anywhere from 2 to 20. It's a huge range, right? So at your 2, you're starting at the renal blood flow, right? So it's going to open up the renal arteries, renal flow, all right? Then you start hitting more. The 10 is where we start. 20 is our max, okay? And the more you get, the more constriction you're going to get. So it's alpha, right? So alpha-1 receptor, so what's it do with the heart?
It shouldn't do much to the,
So if you get too much dosage, what's it going to do with it?
it's going to constrict the vessels around the heart.
Okay,
To
it's gonna
starve it
constrict
more.
heart. So it's going to cause the heart to contract harder, which is not what we want to do, right? So we want small amounts of constriction at the arterial level, right? So basically, we want to take this giant container, shrink it down, constrict all the exterior peripheral vessels, and make it so all the blood is from here to here.
Okay, I don't understand why you're hoping to accomplish that if they're already pushing fluid out of their system into their lungs.
because because our heart is not pumping, okay? So what we need to do is we need to decrease the amount of work the heart is having to do to basically keep the brain and the heart and the lungs perfusing.
Why are you not worried that you're just suddenly gonna have flash pulmonary edema?
Why would you have flash pulmonary edema?
Because you have all this fluid that's now concentrated in that same area.
But it's not, so you're still down here, right? So you still have all the blood and stuff. All it's doing is so what are the receptors called that increase blood pressure?
Baroreceptors?
Okay, so all your baroreceptors start to affect, so you start constricting things down here, right? So as that happens, you're just basically taking the container, it's not like you're completely taking all this fluid and shoving it up here. Just think of it as, let's see what's a good analogy. Let's see.
The mammalian dive reflex?
Pushing on a hose rather than completely squishing it.
So I can't think of a good analogy. So the idea is you're not going to completely overflow them, okay, with the fluid. You're doing just enough to tighten things down to slightly shunt. You're not taking all that. You're just basically doing just enough because we are only going to give enough dosage. We're only going to do enough vasoconstriction to bring the pressure up to back to our 90-ish range, okay? So as it goes, our heart rate's probably going to bump just a little bit, okay? But we're just going to titrate our dopamine at that point. We're not going to just flow it. It's not just a set dose. Everything is a titrate dose. We titrate it to the blood pressure that we want. So once we hit our blood pressure, boom, we shut it down again, or we decrease it. Okay? So you're not like throwing all this medication in all at once, because it's a very titratable medication that we're given.
Isn't
Okay.
like our blood pressure like relatively okay though right now?
Yeah, right now.
Why do you even want to give dopamine?
So I was just going to talk about this. So this is where you're going to bottom out the pressure now. So before we give our dopamine, we've now bottomed out. We're at 60. We have our chest pain. Okay, so we're not getting the blood supply that we need. So now our blood pressure drops into the 65 over 35.
So what you're saying is this current patient is fine.
Fine, yes.
What the dopamine is for is for our pressure
Pressure
to drop down
drops.
in the 60s
Correct.
range.
Okay.
Yes.
So then we've seen a change in our patient.
Yes. So your patient is decompensating now. Right? So we're down to that point. We're at 65 over 55.
And what happened with your patient that you had?
Let me tell you. Okay, so we're gonna give dopamine, right? Everybody agree with that?
Yeah, is that kilogram per minute? Mic per kilogram per
Mike,
minute?
per kilogram per minute, yes. You guys know how to do that math?
Not quite yet.
Yeah.
All right, so a couple different ways.